I will request the respected chairpersons kindly to be on the stage. Hello. In the continuation of the next session, I will request Dr. Manoj Gupta, Dr. Pankaj Chandra, and Dr. Vikram Nigam to kindly chair the session. I invite Dr. Jayan Sen, Dr. Kamraj Singh, and Dr. Ravi Gar kindly. Have your presentation been loaded, sir?
Invite Dr. Jensen to give his presentation.
Good evening, everyone. So first of all, a big thanks to the organizing committee for their kind invitation and having me here. And this case presentation to follow Dr. Tanna and Dr. Rajgaonkar's work uh, takes you on a different plane. Okay, so this is an intra-articular fracture of the distal humerus, and we did what most of you would do: fix it. So this is how we fixed it. We did an olecranostomy and we had a 1990 plate, and very recent. And this is at 2 months follow-up. I also have the same concerns as my previous speakers. Yeah. Video hai. Hopefully it will work. Why should it not work? चलाओ ना यार एक बार नेक्स्ट स्लाइड पे वीडियो दिखाओ इट वर्क्स नवीन भाई old is gold. So I think we'll accept this result and we are very happy to have it. 2 months and great range of motion. Yes, sir. Okay. Just a minute. Yes, if only it would go back. भैया बैक कर दो और बैक कर दो और बैक 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 एक और बैक दो बैक और कर दो एक और yes yes maybe one should have been a shade longer but I've tried to digitate the screws so probably that yes
Stress
yes
riser at
got
the
it
same.
sir I appreciate your point thank you sir चलो 3-4 स्लाइड आगे कर दो एक दो और एक और and so this brings me to this case अरे भाई पिक्चर पहले ही एक्सपोज हो जाती so this is that terrible triad that we would all call and this is actually what we call a kima fracture of the distal humerus along with the coronoid and when we exposed this is what we had in hand next please next please and this is just the distal humerus multiple pieces and why we have it on the table because when we saw the pieces we had no idea how to try and fix it so I went back to my residency days and what we did was we decided to fix the coronoid the ulna hello next please so what we did was we fixed the ulna we fixed the coronoid and did an excision of the distal radius and smoothened it and stabilized it with 2 K wires and held it in a plaster. I don't know how many of you would agree with it. कुछ radical कर दिया. Removed the whole of the distal humerus, all the small pieces which I just couldn't figure out how to fix, and this is what it looks like at about 6 weeks post-op. And at that time, I removed the 2 K wires which were holding the olecranon and the distal humerus. Next, please. And over a period of time, there was a slight migration of the plate and it was coming out and we removed it at about 1 year follow-up. That's what you see on your right. The coronoid and the ulna have united. Next, please. This is him at his follow-up at about 1.5 years now. Next, please. Next, please. Stable here. Next, please. Please play the video if you can. So this is what his range of motion is. Next, please. Please play it again. This is his grip strength. This is his strength of flexion. This is the strength of extension. I don't know if I did right, but probably it works for this guy. Thank you, sir. Yes, please, sir. Yes, sir. Yes, sir. Yes, sir.
Suggestion is
Yes, sir.
take it out on one side of the humerus because these wires tend to break quite often.
Okay.
If it breaks, you will never be able to take it out.
Okay.
We take it out either side of the uterus, so that if it breaks, we take it out from that side.
Okay. And even if it breaks, we can leave it there.
That's the different part.
In all my humility.
I think the patient should be there and the leave it there. I think it's all treatment was very well and it breaks down.
Yes, sir. I think I will take your suggestion. I hope I don't have to do a distal humerus of this kind again. And usually I will try and get a fixation, but it works. It's a bailout, not to be ashamed. But the important point is get the ulna and the olecranon perfect, and that will still work for you.
I think in the days when we were doing, I had to go arthroplasty
Yes, sir.
for a strip band. So this is what we were doing.
So exactly, the inspiration is from my training days because I saw my seniors do this surgery more often. At that time, we didn't have that many fixation techniques. Yes, sir. Thank you, sir.
I would like to invite Dr. Kamraj Singh for his talk.
Thank you so much. Very good evening to everyone. After such a long, rich academia, I'm coming down to the very basics. There's a small case which I'm presenting. Can we have the slides? Pointer, I guess, pointer. हाँ. ये ना? ठीक. हाँ, फुल स्क्रीन है ना ये? फुल स्क्रीन कर दीजिए. फुल स्क्रीन ना. This is a case which had come across, operated at many places. It was something what we call the COVID cases. A 25-year-old young female, history of RTA at the first wave of COVID, then the second wave, operated many times at different places. She had come to us with a midshaft fracture of the radius and ulna with a nail in situ in the ulna, operated many times with a discharging sinus from the elbow. Now, the issues at hand that we have been discussing since the early afternoon has been union instability, hardware infection function. So that is what we try, what we aspire to achieve. Now, the first surgery that she had undergone, she had come with this, and you can see this implant breakage. We can see the span of the plate is less, this is the implant failure, and naturally this had to be revised. During those restrained time, this was operated elsewhere. The surgeon just went ahead and did another surgery. Now, what we would expected him to have put a longer plate and have a better fixation, but again, the constraints of the COVID era. So, in due course of time, this screws also loosened, and here another surgery was done by a third surgeon. Hello? Okay. It's all humble jumble. Okay, I'm coming back. Now, the issues that we've been discussing since early afternoon are the same. This was the second surgery done. There was implant loosening again. Now, the surgeon went ahead and he put a longer plate. Again, there were issues. We don't have very good quality of X-rays. The plate walked off again. And now the question, again, the surgeon, in all frustration, he removed all the implant and sent the patient with this, a nail with a cast. Now the question, what do we do next? Here we have a discharging sinus at the elbow, a ununited both bone forearm, and we have an infection to control. So we have the various options that we have to deal with it. We are dealing with instability at the forearm, external fixator application, antibiotic cement usage, masculine technique, and a plating bone grafting. In sequence, when we went through the options, we found that there's a lot of literature, but there's nothing dedicated to the infective non-union of the forearm, except for one paper and research which is given by Mangal Parihar, which is the only series. Otherwise, all the non-unions infective are dedicated to long bones, and that to most of the tibia. We refer to other cases. We discussed with many other people about similar cases. And so finally, we came down to the control of infection. There was no sequestrum, there was no necrotic area, or there was no obvious focus of infection except the tip of the olecranon from where the discharging sinus was coming. And we did an MRI to rule out any other source, and it was established that the radius is pristine and the ulna is only involved. So we took a pus swab, we did the basic blood markers, we did remove the nail, after which we of course did the MRI, and we considered antibiotic cement nail and for the future plating and grafting. Now the biggest concern after we added antibiotics according to the culture which was obtained. The biggest concern with nailing cement nail, antibiotic impregnated cement nails, is the remnant cement mantle which stays back when we pull out. So we gave a hair bend. We used a K-wire. During the surgery, we took a square nail, we gently bent it and cut off the tip and used that to scrape the canal. We did an open deduction. We debrided the ends of the bone. We got the paprika sign, good vascularity at the end of the bones. We scraped out, gave it good wash, and then we prepared the nail. In this technique, we injected liquid cement and we pushed in the nail. So this is the kind of structure that we finally got. We got it full length. There's just a demo thing which we have put here. But the important thing was we put this bend so that later on when we pull out the nail, we don't have a cement mantle left behind, which is one of the most common complications and a source of further infection. So this is what we achieved. We got the nail in with a cement mantle, and we surmise that as per textbook and literature, it is the efficacy of the cement nail would be for 6 to 8 weeks. So now the issue was what to do about the radius. So at the end of 1 month, we did all the markers and we found clinically this fracture had stabilized. We went in the C-arm and saw that there was no rotation at all at the radius, although there was no callus, and the blood parameters were all, inflammatory markers were all normal. So we went ahead and we did a plating of the radius. The worry here was the variance, the worry of the shortening and the length of the radius and ulna. Once we reconstructed the radial bow, we got a good fixation. We were able to beautifully reconstruct the radial bow, and we had the ulna in a good alignment. So that is where, as of now, we are. Now, the question that we want to discuss and understand, how many of us are actually doing forearm nails or have experience with it, the masculine technique, or the accession of the segmented, sequestered bone and putting spacers, the use of fixators. Here, we did not use fixators because there was already a canal which was compromised, and we were not very happy about using a fixator. There was a lot of scarring also, almost 5-6 surgeries done, implant put in, taken out, put in, taken out on 3 occasions. So almost 6 surgeries in the same incision. This is where we are today, and we have achieved our union. We are in the line of the union. We are line of stability. Hardware is in place. Infection has been controlled. Function is awaited. And now the result we can put up in the next plate score because there's a never-ending series. Now, simple problems, simple measures, and that's where I end the case. The question, I would like it to generate a debate as to what are the options that we have when we are faced with infective non-union. When do we decide to resect bone, put a cement intercalary structure? So those are the questions that I would like to be taken up by the august faculty here. Thank you so much.
You should not consider the same thing to do again. And that is what you did, and you got a result. So congratulations.
Okay, thank you, sir.
Thank you,
Any
Dr.
input from
Kamalraj.
Tanna sir or Dr. Naveen Thakkar, sir?
No, I think that cemented wire which you put in with the bent, it was a good idea because probably if the cement is the one metal, it will not come out. Otherwise, the cement will remain inside and the wire comes out. Here, probably you have not yet removed the wire, have you? You have not removed the wire.
No, we have not removed it as of now.
Because here also, when you remove the wire, I am not 100% sure that the cement will not remain inside.
Or you may not be able to remove at all the wire. And that is also possible.
I fear integration of bone onto the rough surface of the cement. So we are at about 5 to 6 weeks. So we are about to remove it in a week or two.
Then you are going to fix it.
Then we will see. I will just put a cast because the ulna is well aligned, and we have one thing I forgot to mention. When we put the radius plate, we grafted it, and we grafted the ulnar side also.
Okay.
We took
So-
advantage.
so
We
that-
took advantage of
But
that.
that graft also you can imbibe in the antibiotic, and that will also work as a local antibiotic delivery system.
Okay.
That
Another
is an additional tip you can do that.
Okay, sir. Another thing that we speculated that since the antibiotic nail is there, the textbook says 6 to 8 weeks. So we did the plating at about 3 to 4 weeks. So the leaching out of antibiotic would cover the radius as well. So it's just a thought, a concept which we are discussing. Anyway, thank you, sir.
Thank you.
Okay,
Thank you, Dr. Kamalraj. Now we come to the end of this session.
I will now respect our respected speakers kindly to come on the stage to receive the memento. For the next session, I am inviting Dr. Govind Pandey, Dr. S.M. Dwivedi, and Dr. Amit Mishra to kindly chair the session.
मेरा लैपटॉप में तो केवल ऐसे ही पोर्ट है केवल यूएसबी पोर्ट है और कुछ नहीं ये तो आ गया
हेलो हेलो
Wonderful.
I will request Dr. Ajit Tiwari kindly to come on the stage and give his deliberation.
Very good evening, friends. Thank you, Allahabad Orthopedic Association's Dr. K.D. Tripathi sir, Manishi sir, for this opportunity to talk me on this PlatesCon 2. I was also the part of the PlatesCon 1 and now on the 2. So I'm going to talk on the fragment-specific fixation of the distal radius. So most of the people we are, I mean that every orthopedic surgeons deal distal radius fractures. But what is fragment specific? What is column specific? Do we really need to worry about this? Many a time you might have seen that the horrible X-rays with excellent outcome, excellent functional outcome. Many times you might have seen the beautiful X-rays with the bad outcome. Then should we worried about the fragment specific fixations? Yes. The answer is yes, and I'll tell you why. Because those kind of cases where you're seeing the bad X-rays with good outcome and the good X-rays with bad outcomes, they are the outliers. They are not the routine. So the anatomic fixation, articular congruent maintenance of the intra-articular path, and you know that then and good fixations will have a better outcome. So I have no disclosure. I have no any financial relationship with any kind of companies. So he is 28-year-old young man, right hand dominant student. He has a fall on out stress injury to right wrist and pain and deformity. So he has the X-ray. So if you see this X-ray, there is comminuted fractures, and you all aware about all these radiological parameters. I think everyone knows these parameters, but these parameters, which is less talk, is the teardrop angle and the anteroposterior distance. So what is teardrop angle? Teardrop angle is basically, it's around 70 degree, and which tells us about the orientation of the volar lunate facet fragment. And the anteroposterior distance, basically, which is, it means that if an AP distance is increased, it means there's impacted fragment is there in intra-articular part. So we should always worry about the anteroposterior distance and the teardrop angles. So this is the radiograph. Then should we go for any other investigations? This is the radiological angles. So for the better assessment, we should always go for the traction views X-rays and the CT scan. So when we should go for the CT scan, when we feel that there's increased anteroposterior distance, means there's impacted fractures there. When there's increased teardrop angle, means that the volar lunate fragment fracture is there. There's high energy injuries. And when there's scaphoid impression fractures, where the and under the suspected carpal injuries. So this is the CT scan. If you'll see the CT scans, here is the volar lunate fragment, and this is the dorsal combination kind of that, and you'll see that this is the volar lunate fragment, and this is kind of a rim fracture. So if you'll see that this is a kind of a rim fracture. And so here the Reccoli and Regazzoni have given the concept of the columnar classification. So distal radius is not a monoblock. It's a 3-column. One is the radial column, and there's intermediate column, and third is the medial column. So what is the radial column? Radial column is basically this radial stellata and the scaphoid facet. And the medial column, which is the lunate facet, I mean the lunate fossa, where it's a load bearing, and it has a 2 component, volarly the volar lunate facet and the dorsally the dorsal dipunch. And it also the important, there's, if you'll see that this is called the sigmoid notch. This part is very important for the pronation and supination. So if there's a perfect reduction is not there in this sigmoid notch part, then the pronation supination will be restricted. And third part, which is the medial column, is that the ulna, the distal radio-ulnar joint, DRUJ, and the TFCC, where is the tip of the ulnar stellate, TFCC, and the distal radio-ulnar joint. So which is very important in the pronation and supination. So think fragment, think column. So now I'll talk about the different fragments. So here's the Robert and Madoff has given classification of fragment-specific classification. So what are the key fragments? What are the important fragments which we should not forget and always address those fragments? So one is the radial stellate, another is the dorsal wall, impacted articular fragment, the dorsal ulnar, like dorsal dipunch, like this dorsal dipunch, and the volar rim fragments. So these are the important, are the key fragment which we should always address and we should not forget. So if you'll see this CT scan of the same patient, you can see that this is volar rim fractures, there's radial stellate fractures, and so this is X-ray. And what is watershed line? Many of the people, we are not aware that we have plethora of implants, or bunch of implants. We have extra-articular plate, juxta-articular plate, rim plate, variable angle plate, fixed angle plate, radial stellate plate, dorsal plate. Which plate where we have to put we should always know. So there's a watershed line. What is watershed line? It is the line which is, it's imaginary line. There's no line, in fact. It's imaginary line which is distal to the insertion of the pronator quadratus. So our extra-articular plate comes here. Our juxta-articular plate comes at the insertion of pronator quadratus, are just proximal to the watershed line. And our rim plate comes, which is over the watershed lines. So what is difference between the variable angle and the fixed angle plates? So fixed angle plates, you cannot change the direction of the screws. But variable angle plate, you have the luxury of around 15 degree anterior, posterior, any direction. You can, in the 360 direction, you can get the freedom of 15 degree, and you can direct this screw. Suppose that your plate is quite distal and you want to put the screw little bit proximally, you can direct, because you have freedom of the 15 degree. Radial column plates, these dorsal plate and radial column plate, they are specifically for the fragment fixation. So Maloney and die punch has given the classification of die punch fractures. You know that there's Wolff law. So what is Wolff law? Wolff law is that the places where the ligament is inserted have the maximum bone density, or the maximum trabecule is there. And most of the fracture pattern which you'll see in the distal radius is always like in between the ligaments. So where the ligament is inserted, that place is quite strong. And where the ligament is not inserted, that place is weak. So most of the fracture pattern, most of the fracture lines goes through that place only. So dorsal plates, these are the plate which is indicated basically for the dorsal die punch fractures, are the isolated dorsal fragments where there's volar cortex is intact. So the approach, you all are very much aware about the FCR approach. I think Sudhir sir will tell about the approach and all those things. So how to restore the radial length? Many a time you require the brachioradialis release. So until unless you will not release the brachioradialis, you cannot achieve the length, radial length. So all fractures which is more than 10 days, you have to release. For the columnar platings, for the subperiosteal, and until the tendon of the first compartment are seen. It's very important to see the extensor tendon of the first compartment, because there is high possibility that you can injure the first extensor compartment tendons when you are releasing the brachioradialis. So go to the subperiosteally, release the brachioradialis, restore the length, do temporary fixation, and then apply the plates. So this is intro fixation of that. As this was the volar, this was the rim fracture, so I applied the volar rim plates, and this was the fixation. So, and this was after the surgery of the 2 weeks. Important, when you're putting the rim plates, it is important to always keep in mind that the C for the FPL irritation at the around 3 to 4 months, EPL rupture may be a cause, and the early implant removal should be done. After 1.5 year of the follow-up, this is the kind of outcome: is full flexion, full extension, full pronation, and supination. Now we talk about the intermediate column, or the lunate facet fragment. Volar lunate fragment, which is extends volarly, distally, and the ulnarly, which is attachment of the short radiolunate ligament. So you can see that this is the volar lunate facet, and this is the short radiolunate ligament which is attached at this place. This is the most dangerous fragment, I'm saying, because if you will not tackle this fragment, this will not excuse you, because the wrist is going to subluxate or dislocate if you will not handle this fragment. So radiologically, as I told, that you should always see that the teardrop angle, if teardrop angle is more, it means that there's a definitely there's a displacement of the volar lunate fragment. So what happened if the lunate facet is not fixed? Suppose that fracture is there, you have not fixed. So this is the short radiolunate ligament. This is short radiolunate, and fracture is this. This is the volar lunate facet. If you have not fixed, the whole corpus will subluxate volarly, and wrist will be dislocated. So how to approach these facets? extended carpal tunnel approach, or you can go on the little bit medial side and go in between the ulnar and the palmaris longus tendon. And this is the hook plate. This plate is available in India. You can, there's animation of this. Oh, this is not moving. Sorry, it's not moving. So this is it's available. You can see anywhere. So, yes, sir.
Make it fast.
Okay.
Time.
Yes, yes. So what are the other options to fix the volar lunate facet fragment? You can use a single screw with the washer that acts as a plate. You can put the wires. You can use you can put the anchors. You can use the small wires like a tension band wire we do. And or you can use the ithibond like we do the rotator cuff while the proximal humerus fixation. You can put the suture there in the ligaments and you can tie with the plates. So this is another patient which has you can see that the dorsal dipunch fracture is there, and that was a hand fixed with the dorsal plate and the radial styloid plate. So this was the big fragment of dorsal dipunch which was fixed with the dorsal plate and the radial styloid plates. So what about the medial column? I mean that what about ulnar styloid fractures? So these are the multiple series which has shown that the volar plating, after the volar plating of distal radius fractures, location of the ulnar styloid fracture is irrelevant and no effect if you left alone on the wrist function and the pain and basically the pronation, flexion, extension, and ulnar deviation. So what is the treatment algorithm for the ulnar styloid fractures? Assess fracture geometry with CT as needed. All styloid tip fractures left alone. Styloid base fracture, if radius non-op, then leave alone. If the radius, you are doing the fixation, assess the distal radioulnar joint stability, and if stable, leave alone. So how to assess the distal radioulnar joint stability? Most of our teachers has told that, you can say the classical teaching is that the piano key sign, check the piano key sign and check the stability. But I think this is absolutely wrong. The reason behind the side which you are checking the distal radioulnar joint stability are doing the piano key sign, the patient is anesthetized. That side, the muscles are relaxed. So you can get the wrong impression. So what I do that, I hold the whole wrist in between my two palms and rotate and see that if the ulnar head is touching my hand on the either side, it means that the distal radioulnar joint is unstable. So if it is unstable and no ulnar styloid fractures, put a wire from the ulnar to the radius. Always remember that don't put wire in this through the sigmoid notch because that can cause arthritis. It should be a little bit proximally. So I want to conclude that identify the pattern of the fracture, think fragment, think columns, address all important fragments, correct intra-articular step, and choose correct implant according to the fracture geometry. I have started fellowship in hand surgery. Any resident or the person who want to learn the hand surgery or do the fellowship under me, they can join me, or they can send me the email and they can contact me. Thank you so much for joining us. Thank you. Thank you so much.
Thank you, Dr. Raj. Thank you for the nice talk. Our next speaker is Dr. Sudhir Kumar. Yes, you can
without question. Oh, brachioradialis release, you said after 10 days. You don't do a brachioradialis release in fresh fractures?
So if many times what happens, if the fracture is old, if it is 10 days old fracture, then you have to release it. Many times in fresh fracture, you may not need to release the brachioradialis. But if it is old fracture, like 10 days old fractures are the more.
Then in a fresh fracture, when do you release?
So when, yes, in fresh fractures, when you're not able to, correct the radial length. So because of the pull of the brachioradialis, you cannot correct the length.
So whenever there is a radial styloid fracture, the brachioradialis pulls it. So you have to neutralize the forces. So that's the reason you have to release the brachioradialis.
Yeah.
And what is the problem? You said while releasing the brachioradialis, your extensor first compartment might get injured. Why?
So what happens that there are two things. Either you can release the brachioradialis at the site of the fracture, where it is a fracture. But I prefer to release from the radial styloid.
Yeah.
I go subperiosteally because the brachioradialis and extensor compartment, first tendon of the extensor compartment, first extensor compartment, they are very close. You may confuse with the first extensor compartment. If your blade is little bit, that the lateral side, you can injure the
So brachioradialis lies exactly
because we
beneath
are lack of
beneath
time.
the two tendons.
We are lack of
And once the tendons are out, you can release, and you have to release it from the radial styloid only. You can't release at the fracture side.
discuss afterward.
Basically, we have to neutralize the force.
Sudhir sir, you can start with it.
Good evening. Distal radius fracture, I am going to talk about the techniques. These are the learning objectives to identify the various types of distal radial fracture and when you are going to perform the open reduction and internal fixation. Life is very simple. Once you know how to approach the distal radius all around the 360 degree, you can approach the distal radius from the front, from the side, from the back. Even if you are willing to have if you are going to tackle the DRUJ, you have to go on the medial side of the distal radius. So exposure is very simple. Only one thing you are supposed to know how to identify the structures. Plaster application, very good technique. It gives a good stability, but you have to follow the patient to get a good result. Putting the wires like a Kapanji technique or putting a wires in the different fragments is going to give the stability, but same time immobilization in the plaster is mandatory. Another example, putting a X fix. Sometimes we do think putting a just putting external fixator is probably a very good thing for the patient. But many times patient may not be happy because of the something is hanging in the distal part of the forearm. One. Secondly, the results may not be encouraging all the times. What you think is simple may be very complex in such situations. So finally, the results, you may not be going to get a satisfactory result in such conditions. Now, the question of the plates and the screw, we are going to put the internal devices, but how and which plate you are supposed to use it, that is very, very important. These are dictated by the geometry of the fracture. So one can select the plate, either maybe in periarticular, maybe a juxtaarticular, or maybe a variable angle plate with the screws. So some of the examples are there. I have taken the example from the synthesis plates. Like this is a plate which is you are reaching around the nearby the articular surface. These are extra-articular. This is variable angle plate. These are the dorsal plates. So these are the plates which you are going to use it in a common fashion. Distraction plate fixation is one of the technique. Like you are putting, rather than putting an external fixator, you are putting an internal device and placing the plate across the wrist joint by pressing the fracture in such a way that you are going to achieve the reduction, and removal of the plate is mandatory when the purpose is over. In such condition, you will be able to maintain the length of the radius, and many times this may be a salvage procedure in a difficult situation. Another example where the plate application is good enough to achieve the stability and the reduction in such difficult conditions. The approaches are very simple. If you are going to do it from the palmar side, once I am going to touch the thumb and the small finger, the tendon is standing out in between the palmaris longus. Between the palmaris longus and the FCR, the median nerve. So what you are going to protect is the radial artery and the median nerve. What I do and do prefer to propagate to my younger people, directly take an incision directly over the flexor carpi radialis. Inside the outer layer of the